orthopedic examination of look, feel and move. What comes after look, feel and move?
Special test.
Okay, neurovascular and special test. Okay, neurovascular screen. Okay, not testing the whole neurovascular, but just a screen to pick up any red flags. Then any special test. Alright? So, the main objective of foot and ankle surgery, which is a subspecialty of, someone close the door at the back, subspecialty of orthopedics. Anyone can tell me quickly, what would our patients come to clinic complaining about? Alright, number one is pain. So many of them come and tell me that they have feet pain anywhere on the foot, pain. Okay, number two?
Deformity.
Deformity, very good, Omar. So deformity is actually a very main point in foot and ankle examination. Okay, they will tell you whether they can tell you whether they have a flat foot deformity, which is still a deformity, although some flat feet is within the spectrum of normal, maybe at the outer borders of your bell-shaped curves. Okay, you know, right? Bell-shaped curve and whatever, right? Okay, or they may come to you complaining of a high arch, or the foot may be completely deformed because of a previous infection, multiple surgeries, like in a patient with diabetes. Okay, which is the one most important thing about foot and ankle examination, that you're not strong enough to pull the door. Tarik, it's quite heavy. So, diabetic foot examination is the one most important examination that you need to know for foot and ankle, because this will definitely come up for your exams. This is the backup cases that we have from the ward. If one of our patients during exam suddenly say, I can't come because I have COVID and I have to be quarantined. Okay, so diabetic foot and ankle examination is the most important one that you need to know. Otherwise, general foot and ankle examination, you're gonna less likely meet in your exam lah. Okay, unless you have something like a flat foot or high arch, then maybe some form of deformity. Okay, so what is the consequence of a deformity? Why would the patient come complaining of a deformity? It will make them difficult to
Walk.
walk. Will it make it difficult for them to walk? It's gonna be difficult to wear a normal shoe, right? Okay, even a flat foot, the severe flat feet, maybe they might even complain to you that their shoe wears out very unevenly. Okay, because their foot is not normal. Okay, so all those diabetic with a very massive bad and a disfigured foot, they can't wear normal shoes. They have to go and make custom shoes. Okay, so pain, deformity. What else will they come to clinic complaining to you about? Swelling. Okay, swelling, yes, which will also cause a difficulty to wear normal shoes. So swelling can be a local swelling, or it can be like a edema, generalized swelling of the whole foot. Okay, anything else?
Numbness.
Okay, so some nerve symptoms, yes, can happen in upper limb, can also happen in lower limb, whether you have any nerve entrapment, like your carpal tunnel, or similarly can happen in the lower limb as well. The lower limb version of the carpal tunnel is the tarsal tunnel. Okay, your carpal bone, you got your tarsal bone, you got your carpal tunnel, and you also have your tarsal tunnel. And the nerve can be trapped there as well. Okay, anything else?
Wound ulcer.
Ulcers, very good. So wounds, so diabetic feet. Okay, or from anything else, burns, or whatever else reasons, ulcers, okay, corns, calluses, thickened skin. Okay, alright. So the main objective of foot and ankle surgery is to restore the patient to have a painless plantigrade. What does plantigrade mean? Anyone knows?
On the floor with metatarsal forward.
Sorry?
The foot contact with the floor with metatarsal forward.
Okay, so the foot in total contact with the floor. Okay, in a neutral position. That means it's not dorsiflexed, it's not plantarflexed. Okay, it's 0 degrees neutral. It's not supinated or pronated. Okay, it's flat on the ground, the heel touches the floor, the metatarsals touches the floor, the foot faces forward. It's a plantigrade foot. Okay, so painless, plantigrade, shoeable, able to be put into a shoe, because nobody walks around barefooted nowadays unless you live in the jungles of our Amazon or something. Alright, painless, plantigrade, shoeable, and stable. Okay, so differing from hand, where we would like dexterity, where we would like flexibility, where we would like suppleness. You know what supple is, right?
Gentle.
Yeah.
Yeah.
Is it?
So it's not stiff. Okay, supple is basically the opposite of stiff. Okay. So foot and ankle is the opposite of that. Okay. Dexterity is not important unless you are someone who has no hands and you use your feet to paint. You know, you are OKU. Okay. Then dexterity of your toes are important. But for us, no, it's not. Okay. We would prefer something more stiff, so that we are stable when we are walking, especially on uneven grounds. If you have a very lax foot, you might easily twist. Okay, I'm sure many of you has got an ankle sprain before, right? I mean, who's never sprained their ankle before?
It will be spoiled.
Dude.
She runs, but wow, amazing.
Amazing. You take very good care of your feet. Okay, so four main objectives for foot and ankle. Okay, painless, plantigrade, shoeable, and stable. Alright, so going into examination of foot and ankle. I should start bringing all my pointers and everything again. Okay? Then you can control the slides, not at the computer. For 2 years we are.
Last time we did that with Dr. Gait.
Okay. So a little bit back to the anatomy, because I'm sure this is something that you didn't really pay much attention to when you're doing your anatomy class in first year. By the way, you guys are now systems, right? Blocks were so long gone. Anyway, when do you do your musculoskeletal system?
First year.
Okay. So, similar to the hand, you have your phalanges. Okay, remember the thumb only has 2. If you have 3 in your thumb, it's gonna be got deformity such as that lah. Okay, so your thumb only has 2. So similarly, your great toe also only has 2. Okay, your lesser toes, they all have 3, similar to your fingers. And then you have your metatarsals, and then you have your tarsal bones. How many carpal bones do you have?
7.
She looks too pretty, try to catch her. She looks too pretty, try to catch her. 8. How many tarsal bones do you have? 7. Okay, so the 2 main tarsal bone is the talus that articulates with the tibia, and then underneath the talus is the calcaneum, which is your heel bone. Okay, refreshing. Okay, so you have the tibio-talar joint, okay, which is the layman's term for your ankle joint, the one that's main movement is going to give you your dorsiflexion and your plantar flexion. Okay, another name for this is actually the talocrural joint. It's the same thing. So if you encounter this name, don't be surprised. Okay, it can be used interchangeably. Okay, the joint in between the talus and the calcaneum is called the subtalar joint. No one calls it the talocalcaneal joint. Okay, it's called the subtalar joint. Okay, so if you want to talk about things, you have to make sure that our nomenclature is correct. Because it's underneath the talus joint, so subtalar joint, right? And then you have 5 smaller tarsal bones. Okay, so your navicular, and there's 3 cuneiforms: medial, and lateral cuneiform. Medial, middle or intermediate, and lateral cuneiform, and your cuboid. So each cuneiform will articulate with each 1 metatarsal, but the cuboid articulates with 2 metatarsals here. Okay, so 3 cuneiforms will articulate with the navicular, which in turn articulates with the talus at the talo-navicular joint. So the talo-navicular joint is quite important because a lot of rotation of your feet happens here. Okay, so you got your calcaneal cuboid joint and of course your cuboid with the 4th and 5th metatarsal. So there are two, this joint, which is a tarso-metatarsal joint, is called also the Lisfranc joint. Okay, and this talo-navicular with calcaneal cuboid joints collectively together is called the Chopard joint. It's people's names lah. See, in foot and ankle, a lot of people have staked their names on a lot of things. Okay, so from an X-ray, can someone tell me what bone is this?
Keyboard.
Navicular, because you see it is together with the talus. What bone is this?
Calcaneal.
Alright. Okay. So you have this your
Tibia.
here your
Fibula.
Alright. Okay. So we can roughly divide the foot and ankle to foot to 3 regions. Anyone can tell me quickly? Forefoot,
Hindfoot, hindfoot.
Right, very easy, right? Okay, so we shall be very systematic about things. We'll start by looking at the forefoot. Okay, and you open your shoes. So of course you're going to tell the patient, okay, please open your shoes, open your socks. If you have the time and you're very confident about your examination, quickly look at the patient's shoe just to see if there's any signs of uneven wear, but his shoe looks fairly new, so they are not going to be very reliable. Pretty new, right?
Since the year, so
Really?
relative lah.
Tak cukup guna. Tak cukup jalan ke what? I mean, we were all locked up for a good part of last year, right? Okay, so your exposure should at least expose up to the knee.
This is possible.
Yeah.
Good enough. So you're going to tell your examiner, ideally I would like to expose up to the hip, but due to patient's modesty, I'll just maintain it as such. Okay, so make sure that the knee patella points forwards. When you want to examine any lower limb, patella should point forward. Yeah, come sit forward, take the other chair, take this chair. The carpet, can you sit on the carpet if you like. Or stand around. Any deformities in the forefeet, anyone knows? 2 more chairs here. Come. Hallux valgus, very good. What is hallux valgus?
This ah.
Very good. Navin. Nik. Navin, okay. So as we see in the picture, lateral deviation of the big toe, most commonly you see in what? Men or women? Women. Any idea why?
Heels.
Heels, yeah, heels. And also? Yes, narrow, sharp, pointy, fancy shoes, narrow toe boxers. Okay, all this predisposes you to develop hallux valgus deformity. So as you can see here, which are actually quite mild, it's not very severe, but you can see definitely the big toe is laterally deviated, right? Okay, so we look at Omar's toes, very nice and very straight. Okay, so you compare these normal toes with the laterally deviated big toe in the picture. Okay, so a layman would say that they have a bunion. Okay, right, this is a bunion, right?
Bunion.
So people will complain that this is a bunion. So they say they come to my clinic and say I'm concerned about my bunion. Okay, but little they know that this bunion here is a prominence of the metatarsal head, because the joints subluxes. You know the difference of sublux and dislocate, right?
Yeah.
Dislocate is completely not in contact. Sublux is still contact. Correct?
So
Right?
it's not good for those yang shave their bunions lah, because it's the bone.
Yeah, it is a bone. So inside, underneath the skin, it is a bone. But typically, because the contact pressure changes, the skin overlying the bunion typically grows thicker in response to increased pressure. Okay, when we have thickened skin at the sole of our feet, which we call a callus. Okay, not the fracture callus, okay, but callus, or callosity, right? It's because of abnormal pressure. Okay, right, increasing pressure. Right. So the big toe, typically the deformities that we can see is the hallux valgus. But any differential diagnosis to this?
Gouty arthritis.
Very good. Okay, gout is a main differential. If you see the patient is a young gentleman, the toe is like that saying, you think it's hallux valgus. Hallux valgus usually female, a little bit older already, 40 something. Family history also plays a role in hallux valgus. If your auntie or your mom has it, then you are higher risk of getting it. Okay, and of course if you always wear high heels and narrow toe boxes. Okay, gout can also have something like this, and they can also have a swelling here. Do you know what's the name of that swelling? Gout.
Profile.
Okay, it is a profile. Anyone heard of a podagra before? Okay, so it's a specific podagra, a swelling over the first metatarsophalangeal joint in gout. Okay, so the toe generally usually is straight though. It doesn't really laterally deviate, but sometimes it still can, because the gout itself destroys the medial ligaments, causing it to be weak and lax. Then it deviates laterally. But the lateral ligaments are normal, but the medial side becomes lax, so the toe deviates laterally. Okay, the differential diagnosis is gout. Okay, what are the deformities of the lesser toes? So this is the general deformity you can see in the main big toe. Anything in the lesser toes that you know? Okay, very good. So if this is severe enough, it will crowd all the toes, and sometimes your second toe will go on top or underneath the big toe. Okay, in severe foot, what do you call this? Hallux valgus. Okay, what else do you see in the lesser toes? Okay, what is in the picture?
Mallet toe.
Okay, what's the definition of mallet toe?
Flexion at the distal interphalangeal joint.
Okay, so you can see it's very nice, especially on the second and third toe. Any of you? Very nice and flat all your toes. You see how you can see very clear is all the toenails are facing up. Whereas for me, some of my toenails are facing forward. Okay, so mallet toe and hammer toes are also a consequence of narrow toe box and inappropriate shoe wear. So more commonly also in females or guys who always wear dressy shoes or sports shoes too tight. Okay. So this is a hammer toe.
Oh, I got that.
Okay. So you can see that it's pressure on the shoe and it's becoming a corn. So callus is what you find on the plantar aspect. Corn is what you find on the dorsum. Alright. How about this? Not very clear also. Claw. Okay, so claw toe. So where mallet toe and hammer toes, they are related to tight shoe boxes. Claw toe is related to? Sorry?
The
Muscles. Okay, where do you get claws in your hand? Why do you get claw in your hand? Nerve. Okay, so for your feet also, it's the same mechanism. When you have intrinsic muscle weakness, just like in your ulnar claw, because your ulnar nerve supplies a lot of the intrinsic muscle. What do we mean by intrinsic muscle? What is intrinsic muscle? Okay, the small muscles in the hand. Okay, the feet also have all these small muscles. Do you remember your interosseous muscle, interossei muscles, lumbricals? Okay, these are the intrinsic muscles, the short muscles that is just in the hand, originates in the hand, inserts in the hand. Okay, whereas you have a lot of long muscles also that originate in your forearm, and then have long tendons that go into your fingers, correct? So in your feet also it's the same thing. Okay, so those are the extrinsic muscles, because they originate outside of the foot. Okay, the intrinsic muscles are the ones that originate in the foot, inserts in the foot. Okay, so when you have a similar thing like a ulnar nerve entrapment, so on the foot, when you have weakness in the intrinsic muscles, maybe because of distal peripheral neuropathy. Peripheral neuropathy is distal, like what's the most common? Diabetes. Okay, more often than not, you find people with diabetes having claw toes. Right? So what is the definition of a claw toe?
Hyperextension at the metatarsal
Pharyngeal joint and
inflection and
Interphalangeal.
okay, interphalangeal joint flexion. Okay, another example of claw toe. This one is in, what else can you see from this picture? Arch. What's with the arch? Okay, very good. But you can only tell arch when the patient is weight bearing. Okay? Do not, when the patient is lying on the couch, say, this patient has high arch. Okay, it's not accurate. Patient has to be standing. Right? This looks like it, but you never know. When the patient stand up, tengok flat feet. Then you will have dug your own grave. Okay, so besides the foot, the big toe and the lesser toe deformities, what else you have to look at?
The nails.
Yeah, so very important, especially in your diabetic foot examination. Okay, what is this? What is this called?
Onychogryposis.
Onychomycosis. Okay, onychomycosis. Mycosis is
Fungus.
fungus. Okay, onycho is nail. Okay, then what else you have to look?
Oh,
Okay, so you make sure
fungal.
that you look at the web space. Wait, let me rewind a bit. This is already very specific exam. Look. A lot of foot and ankle examination is a look. Okay. I rewind a bit, Okay, so you same like all the other examination, you have a general inspection first, then only you go and specific inspection. So all this is actually under specific inspection. You're already very near the patient and really looking at the feet. Okay, so your general inspection, of course you're going to see the patient standing, well built, no problems with standing, and then you're going to ask the patient to walk.
Okay.
Okay, so rewind a bit at the video there. So okay, what are the three things that you want to look for in the gait of the foot? That is a gait abnormality, but what are the three main things that you look for in stance phase?
Prolonged stance.
Toe off.
Okay, toe off is the third one.
Heel strike.
Okay, heel strike,
Flat foot.
foot flat, and then toe off. Okay, so these three things you want to make sure that they are there. Okay, so you can appreciate them better in a sagittal profile. That means you're looking from the side. Okay, if you are doing hip examination, it's more important you look from the front because you want to see your trunk swaying, hips swaying, Trendelenburg gait, and all these things.
I can also.
Walk. Okay, can you walk for me, Omar? Okay, so you can appreciate a nice heel strike, foot flat, and then toe off. Okay. So, in flat foot, most common foot drop, which can come out for your exam. Can you have a seat, Omar? What would you expect?
High steppage gait.
Okay, so high steppage gait happens in swing phase or stance phase?
Swing phase.
Swing phase. Okay, when the person swings the leg, it becomes high steppage. Wait, why?
Because they need to accommodate for the
Okay, can you walk again and can you all appreciate his swing phase? What happens when he swings his leg? There's slight dorsiflexion of the foot, right? Okay, this is for ground clearance. Okay, to clear the ground, the foot has to slightly dorsiflex. But in foot drop, what's the nerve palsy in foot drop?
Common peroneal.
Okay, common peroneal nerve, which will cause deficit in which compartment? What does the common peroneal nerve? Okay, anterior.
anterior.
Common peroneal nerve also innervates the lateral compartment. Okay. Common peroneal nerve divides into deep and superficial one, right?
Yes.
Superficial peroneal nerve innervates the lateral compartment, which are your two muscles?
Peroneus brevis and
Peroneus longus and peroneus brevis, very good. And the deep peroneal nerve innervates the anterior compartment. Okay, so most important which is the tibialis anterior, which helps to dorsiflex the foot. Okay, so you have loss of your deep peroneal nerve or your common peroneal nerve. So you have loss of dorsiflexion of your foot. You are unable to clear the ground. How the body accommodates is by increase hip flexion increase knee flexion, thus giving you your high steppage gait. Another deformity in the gait when you have foot drop. Anyone knows? It's during stance phase. Do you think the patient can do a heel strike?
They just flat the foot.
Yes. So when you're doing a heel strike, can you see my anterior tibialis tendon?
Yes.
Okay, this is your anterior tibialis tendon. Okay? It's still contracting to keep your foot from just ramming into the floor. Okay, so there is contraction during heel strike and slow relaxation for your foot to go flat. Alright? So in a foot drop, there's no heel strike. The foot just slams on the floor, slaps on the floor. Okay, straight away to a foot flat position. Right? Okay, so that's one very common example of gait abnormality for foot and ankle problem. And the other one is of course antalgic gait lah. I think all of you know lah. I don't need to say this one lah. Okay. Otherwise, another one that can come out for exam is maybe if you are unlucky enough to get a patient with cerebral palsy. Then you know they have all those funny gaits, right? Most commonly is their scissoring gait, but basically their feet are in equinus. And they don't have a heel strike. You walk like tiptoeing like that. Okay? Less commonly, they have calcaneus gait, where the heel is just on the ground. Foot still reaches the ground lah, but it's not like a nice heel strike, foot flat and toe off. They don't have the toe off component. Okay, calcaneus gait. Right, so less commonly. So you ask the patient to walk. Anything else you want to ask the patient to do before you go into specific inspection? Yes. Okay, so tiptoe in foot ankle examination is important. Why? Can you face the screen? Can you appreciate the alignment of his heel? Okay, how to see the alignment of the heel? You draw a line through the tibia and a line through the heel. Is it in line with the tibia? No. It's slight varus or valgus? It's slightly valgus, yes. Slightly going out. Can you all appreciate that? So later you all go and appreciate your own ones. You look at your friend's one, your friend look at yours. Okay? So the stance phase, in normal stance, the heel goes outwards slightly. See, the calcaneum is slightly going outwards, which is valgus. Right? Deviation away from midline. Okay? And when you tiptoe first, what happens to the alignment? What is medial? Varus. Okay, so the heel moves into varus. So this is the number one thing that you can observe when the patient tiptoes. Okay, if the heel doesn't go into varus, there is a problem with the tibialis posterior tendon, because that's the tendon that's in charge of causing the heel to go into varus. What's the other thing that you can see?
The Achilles.
Okay, Achilles tendon is there. It's not going to change much whether you tiptoe or not. What happens to the arch?
Comes higher.
Yes. So the arch becomes more pronounced. Correct? So the arch, he has very nice arches when he's standing, but they become even more pronounced when he tiptoes. Okay, this is a mechanism of the plantar fascia.
You better pee, man.
Okay, this is the mechanism of the plantar fascia. Have you all heard of the Jack's test? Jack's test is flexion of the big toe. Okay, so this will cause the arch to be more pronounced. So it's the same thing when you tiptoe. Okay, you have extension. Sorry, not flexion of big toe. Extension of the big toe. So you have extension of the toe, making your arch more pronounced. Okay, because of the action of the plantar fascia. Okay, so you all can see your own plantar fascia. So if you are like mine, it's very prominent. Okay, when you extend your big toes, your toes, your plantar fascia will become taut. Why? Anyone knows where the plantar fascia inserts? maybe too deep for you all. Okay, but basically inserts in the heel, inserts at the base of the phalanges. Okay, the base of the proximal phalanges. That's why when you extend the toes, you will tighten the plantar fascia and causing the arch to be more prominent. Okay, so two things you want to look at when you ask the patient to tiptoe. Okay, so the second thing, when the arch comes back, is quite important because you want to differentiate whether it's a flexible type of flat feet or whether it's a rigid type of flat feet. Okay, alright, then only you ask the patient to sit on the couch or your examination bed. Okay, and then go for specific inspection. So you guys, just for viewing purposes, he's going to have his foot hanging. Okay, but for your exams, the patient will be lying down because you don't have a high couch for your exams. You're going to have those low ward beds. Okay, so your examination has to be done with the patient lying down. Okay, but in the clinic, I like to examine patients with their legs hanging, okay, and their legs are loose and free. Okay, so then only you go and do that specific inspection. Okay, there's deformity, big toe, lesser toes, no nail deformity. Make sure you open all the web space. Show that you're opening the web space. Okay, looking for any, what is that?
Candidiasis.
Fungus.
Fungus, yeah.
Okay, fungus can also happen in web spaces. So especially if you're doing a diabetic foot examination, you must look at all this. Okay. Why am I all over the place today? Yeah.
Can ask one of our friends to just sit there.
No. Yeah, okay. I'm still all over the place today. Just now when you were standing up there, let's rewind back to just now. Sorry. Okay. Another thing that you want to look at when the patient is standing, before you put the patient on the couch. So just now I mentioned already, right, that you never should comment about whether there's a high arch when the patient is lying down. So when the patient is standing is the time when you want to look at the arch. Okay. So rewind again. You start, you introduce yourself, you expose the patient, and then you look at the feet. Okay. So the forefoot, midfoot, and hindfoot. Okay. So just now forefoot, we've already talked about it. Okay, we covered everything: big toes, small toes, and nails, and nail in between the nails. Okay. So midfoot, you want to look at the arch. Okay. So sometimes it helps to just try to put your finger underneath the arch, see how much you can put in. Okay, how deep you can put in. Okay, so his can accommodate up to my distal crease, distal flexion crease. Okay, so DIPJ, right? So in high arch, sometimes you can get all the way up to your PIPJ. And if the foot is really flat, sometimes you can't put in any finger at all. But you have to tell the patient when you do this, because patient naturally what they'll do is they'll try to move away from your hand. Apa doktor ni nak sentuh kaki I. Okay, they try to curve their foot away. So you tell them, no, just relax. Then you just try to see. Then you can put your fingers in. Okay, so the arch appears normal. Use the word appear. Okay, because actually the most accurate way to assess the arch is by standing the patient on that. You know, you've seen a foot. Yes, the one that maps your arch. Okay, so grossly seeing from here is not very accurate. Okay, but you can say it appears like there's a low arch or a high arch or a normal arch. Okay, right. And then you want to look at the hindfoot. So forefoot done, midfoot was just looking at the arch. Now you want to look at the hindfoot. What can you see from this picture? Okay, so when you look at his hindfoot from the front, can you see his hindfoot from the front?
No.
Okay, cannot see his heel, right? So the person right in the center cannot see his heel, right? Okay, how about this guy? Okay, so this is called the peekaboo sign. Because the heel, peekaboo, I see you. Okay, what does it signify? Yes, so just now as we said, the hindfoot is slightly valgus, right? Okay, this signifies a varus deformity of the hindfoot. Okay, and then you turn the patient from behind. and you look at the hind foot again properly. So just now you saw a little bit of valgus. Okay, so if it's deformed, can you appreciate that this is not valgus? So you draw a line through the center of the tibia, and you draw a line through the center of the heel. This slight varus, correct, compared to Omar's heels. Okay. Another sign that it could be varus is that you can see the forefoot. How about in Omar? Can you see his forefoot from the medial? Rather, you see the toes on the lateral, right?
Yeah.
You don't see the toes on the medial, right?
Yeah.
Okay. Right. So that's how you have a look at it. Okay. So if the foot is too much valgus, so here this is too much valgus. So usually it's about 5 degrees. This is more than that. Okay. Then you can see even more toes. Okay. Like in this picture. How many toes is normal? Can someone look at Omar's feet again? How many toes can you see when he stands like this? The guy with the camera.
3.
3? 2.5? 3? Is it 3 complete toes?
Actually, it's 2 and a half lah.
Okay, so normal is 2.5 toes.
Yeah.
Okay, so more than 3 toes
The left side.
is means that your forefoot is abduction, abduction. Okay, heel is here. Yes, definitely this here is valgus. Okay, but when you describe the forefoot, too many toes is in abduction.
So what do you say?
Okay, so here's another more clear picture as well.
Too many
Here you
toes
can
as
see
Yeah, tomato sign.
4 toes.
How many is all?
Huh? And the heel is
Last
very
one,
valgus. Right. So another deformity assessment is when you are sitting the patient down on the couch lah. Okay, so just now looking from the back, you're telling okay the heel is in valgus slightly, and then you ask to tiptoe the patient, and you can see that the heel goes back into varus, and you see that the arch becomes more prominent. Okay, then you ask the patient to walk, and then only you see the patient on the couch. Okay, and then only you look at the toenails and the web spaces. Okay, do you all get the flow? Sorry, it was a little bit tunggang terbalik here and there.
So the gait is after the...
Yes. So first you stand the patient. You're looking at the forefoot, midfoot, hindfoot, mainly for deformity. Okay, so you can mention all the deformity of your toes. You can look at the arch. You can look for deformity of the hindfoot. And then you ask the patient to walk, or you ask the patient to tiptoe, whichever first, also is okay. Alright, so the tiptoe, you're looking at those two things. Heel go into varus, arch present. Okay, walking, you're looking at the heel strike, foot flat, and toe off. Okay, and then after that, then only you ask the patient to sit on the couch. Then only you look closely at the toenails and the web space. Alright, look for any bumps, lumps, scar, as usual. Okay, and then what are you going to look for next? This is another part of deformity assessment. I think maybe a little bit advanced, but it's just trying to show you how you look at forefoot abduction and adduction. Okay, so how you do that, if you guys are interested to know, when you look at the bottom of the foot, okay, if you draw a line through the center of the heel, okay, it should go through the second web space. Okay, so you see the picture of 1D. Okay, so it should be a fairly straight line going through the second web space. Okay, but if this line through your heel goes through more lateral, that means your forefoot is going medial, which is adduction. Okay, but if this line through the heel and you draw it up, it goes more medial, means your forefoot is abduction. Okay, so this is how to specifically look at the forefoot deformity of abduction and adduction. Not very important, just for your information lah. Okay, so another thing, 1E and 1F, what it's trying to show you is how to look at pronation and supination of the forefoot. Okay, so So that is seen by the front. Okay, when you look at the front, you look at the heel. Okay, and then you look at the balls of the toes. Okay, so the head of the metatarsals. Okay, so they should be in the same plane. If the head of the metatarsals are like this, what is this?
Pronation.
Yes, so it's pronated. Okay, if the head of the metatarsals in relation to the heel, is like this, then it is supination. Okay, so from the picture, yeah, it should not be an axis through the leg lah. It should be in relation to the heel.
This is supination.
Okay, so this again was what you see on your Hindfoot. This is a very severe flat feet. Okay, and this is the appearance of how a high arch would be, where you can put in many fingers up to your proximal interphalangeal joint. Okay, and then after that you ask the patient to tiptoe, and you see that the heel goes into varus, and then this is the gait. Okay, right. So once you're sitting the patient down on the couch, another thing that you have access to look at is the sole of the feet. So just now I said, if there's abnormal pressure, the skin of the sole of your foot will definitely grow thick because it wants to protect from splitting, from becoming an ulcer or ulceration. Yeah. Okay, so you can quickly see, very nice, there's no callosity anywhere. Okay, but like in this picture, you can see there's a callosity at the head of the which toe? Second metatarsal. So this is the head of the second metatarsal. Okay, how callosity will present. Okay, so here sometimes you can get also, especially if your foot is very pronated. Okay, when you're walking with a very pronated feet, you can get a hypercallosity here, increased callosity here. Right. Why did I put this slide? Okay, sure. Right. So that is it for your inspection. Okay, so you've seen everything. Anything else you all want to ask for inspection? General inspection, walking, tiptoe, and then specific inspection. Okay, clear?
We need to walk on the heel.
Okay, walking on the heel and walking on the toe, these are more of motor power assessment. It's not really an assessment of foot and ankle, but it's more of your motor power, which comes under neurological examination. So not necessary, especially in the amount of time that you have. Not necessary. Okay. But, no one is going to tell you that it's wrong to do, but it's going to waste your time lah. Right? Okay. So after look, next is feel. So as usual, temperature. Can you give me any examples when you have an increase in temperature? I'll try gout. Very good. Okay, acute gout can have a localized increased temperature. Someone?
Sprained ankle.
Okay, if you have a very bad sprain and you have a lot of inflammation going on and swelling, yes, definitely you can feel warm.
Cellulitis.
Good. So any infection can make the feet feel warm. Anything diabetes related? Very good. So Charcot arthropathy, okay, which is related to a diabetic neuropathy. Okay, in the acute phase of Charcot arthropathy, you know, Charcot arthropathy, there's a acute phase going on, then only it becomes deformed foot. Okay, acute phase is when the bones and the joints are starting to get destroyed from whatever reason, because blood vessels too much or the nerves not good enough, whatever. There are a few theories why Charcot happens. Okay, but during the acute phase, when the bones and joints are being destroyed, the foot typically becomes swollen, red, and quite warm. Okay. After that, then only when the bones destroyed already, and then it starts to heal back in an abnormal position, a normal alignment, and then you got the deformity. Then only the warmth and the swelling will go away. Okay, but in the acute phase, during the destruction, it's quite warm, and it's quite swollen, and it's quite red. Right, so warm. So you have done warm, make sure you compare to the other side. Okay, then after that you want to do palpation. Okay, so landmarks of your foot and ankle palpation. Let's quickly go back to the x-ray. Okay, so if you look at the normal foot, you see belakang sikit.
Further back.
Okay. Right. So if you look at the normal landmarks, okay, your medial malleolus, your lateral malleolus, okay, so you can see the lateral malleolus is lower than the medial malleolus. So if you look at your x-ray, okay, can you see that the lateral malleolus is about 1 cm distal to the medial malleolus? That's normal. Okay, and if you see the joint line, it's 1 cm proximal to the medial malleolus. Okay, so you look at your x-ray and you can appreciate it on your patient. The joint line is more proximal than the tip of the medial malleolus. Okay, so you want to assess tenderness, tip of medial malleolus, around the deltoid ligament, which is your medial constraint for your ankle joint. Okay, so the joint line, which is a little bit more proximal than your medial malleolus. Okay, and then your lateral malleolus, which is the most distal one, is about 2 cm longer than the joint line. Okay, and then of course the ligaments around here, which is the most commonly sprained one, which out of 38 of you, only one person has not sprained before. Is it 38 of you?
Yes,
Okay, so this is palpation of the ankle joint. You have to palpate all your joints in the talar joints, okay, and then all your toes and everything. So it's just like a hand examination, everything actually had to be palpated. You might feel a little bit overwhelmed because like, oh my god, so many things to palpate. Okay, but just be systematic, hindfoot, midfoot, forefoot. Okay, so you start from proximal to distal, palpate, right? A little bit places of note that you need to know. Okay, another landmark is here. You know what's this?
Navicular.
Very good. Who said that? Okay, so some people have a very prominent navicular. Can you see mine?
Oh, can.
Wow.
Okay, so this is my navicular. Maybe it's more prominent on the other side. Okay, so this is my navicular.
Oh, I forgot.
Okay, so this is where the tibialis posterior inserts actually, and sometimes you have an accessory navicular bone that makes it very prominent like mine. And sometimes when patient has flat feet, a lot of pressure it goes on this area. That's why the patient complain of pain. Okay, so you can find tenderness here. Okay, so this is one landmark you should know besides the medial and lateral malleolus. Okay, and then how about on the outside here?
Keyboard lah.
No, cuboid is quite hard to feel because it's quite deep because of what is this?
The fifth
Good.
metatarsal.
So the base of the fifth metatarsal. So everyone should go and palpate their own as well. Okay, so these are another landmark of our feet. Okay, so palpate your own base of your fifth metatarsal, and you know it's there. Okay, on the medial side, palpate your navicular, you know it's there. Okay, so you have an idea. Right, so what attaches at the base of the fifth metatarsal? Any tendon? Anyone knows? It's the everter of the foot. So the peroneus brevis attaches at the base of the fifth metatarsal. Okay, is the primary everter of the foot. Okay, so these are a few landmarks, bony landmarks that you should know. Okay, and then of course your toes and everything. So feel, and then another things that you want to palpate is the Achilles tendon behind. Okay, if there's any Achilles tendinitis. Alright, and then also the sole of the foot, most important tenderness here. Anyone has this before? Pain over the heel here. You guys are so young, so tak ada sakit langsung. Okay, so this is common place to have pain for plantar fasciitis. Plantar fasciitis is very, very, very common. You all heard of it?
This is not like standing so long, right?
Yeah, because of standing too long, walking too long.
Then that one got
People
lah.
with who run marathons, they are at high risk of getting plantar fasciitis.
Okay, then I have
Walking,
experience
walking, running. You sakit sini?
bila at rest bila dah after long days like about 20,000 steps.
Oh wow, okay. And usually the pain also comes the first thing in the morning when you turun dari katil.
Oh yeah.
You get the sharp pain here. Okay, so plantar fasciitis. Okay, another common place that you can have tenderness. So don't forget that your feet have soles also that you have to palpate. Okay, and of course the Achilles tendon behind here. Okay, can also have pain, which is also quite common. Okay, another place commonly you can have pain is at the head of the metatarsals here as well. Okay, if there's increased pressure here, then it can be painful. What we call metatarsalgia. Okay, so feel. Quite straightforward. You don't really need to feel all the way up. Hand, you know, sometimes they ask to feel forearm, okay, but not really lah for our tibia, fibula, nothing much that happens there. Okay, so just down there, ankle and below. Okay, and then after that we're going to move. So to understand the movement of foot and ankle,
Doctor,
Yeah.
for feet, do we do the pulses sekali or
nope. So that one comes under neurovascular
Oh,
screen. Okay, so move. So again, passive movement of your foot and ankle is just like the deformity that we were describing just now. Okay, you can passively move the foot into dorsiflexion, plantar flexion. Okay, but when you want to ask the patient, when you want to do your examination and move, you are asking the patient to do active movement. Okay, like in hip examination, you are doing passive movement, correct? You are mainly moving the hip for the patient. You are not asking the patient to do abduction, adduction, internal, external rotation, correct? You're doing it. But for knee, you are asking the patient to actively move, correct? Okay, so for foot and ankle, you ask the patient to actively move. Okay, so can you bring both your feet up? Okay, then you compare the degree of dorsiflexion. This is very good. So you can get about what, 45 degrees. Okay, so you have to look from the side. Yeah. Okay. Okay, can you bring both your feet down? Okay. So the degree of plantar flexion is also very good, about 70 degrees. Okay. And then after that, another two movements that you want to know is inversion and eversion. Okay, everyone invert their feet. Now, if you break this down into three different components, midfoot, ankle, subtalar and forefoot, what happens? Okay. So at the ankle joint, what happens?
is eversion.
Ankle joint is plantar flex. Okay, subtalar joint is inverted. Okay, going inwards or going into varus. Okay, and then how about the forefoot?
Flex.
Okay, forefoot is in supination and just now forefoot we can see whether it's supination pronation, and another one we can see whether it is
Or abduction or adduction.
abduction and adduction, right? Okay, so when you are doing an inversion of your foot, the forefoot is in supination and
adduction.
adduction. It's somewhat going
In.
correct. It's going this way and it's also doing this. Okay, so this is a collective movement with one action. Why does this happen? Because our tendons cross multiple joints at one time. There is no way an active motion can isolatedly supinate the foot or isolatedly adduct the foot. It all happen together with the tarsal joint and the ankle joint and the subtalar joint, because the tendon crosses multiple joints at one go. Okay, so this is the collective movement of supination. So you have to look for ankle plantar flexion, subtalar joint going into varus, and the forefoot going into supination and adduction. Okay, everyone invert your foot. What happens?
Opposite.
So it's a complete opposite.
Extension.
Extension.
Hey, no one says extension.
Sorry, plantar.
Dorsiflexion.
Dorsiflexion. So
Dorsiflexion.
ankle joint only dorsiflexes or plantar flex. Okay, but your toes extend and flex. Okay, so dorsiflexion ankle, subtalar joint, eversion, where the heel goes into valgus, so your heel is going outwards. Okay, and then your feet, pronation and
AD.
abduction. Okay, so a collective movement that forms your active eversion of the foot. So you ask the patient to invert, you ask the patient to evert, and then you ask the patient to flex all toes, extend all toes. Okay, so these are the active movements. Right? If you think there's any reason why, any particular reason you want to test, like you see, the active dorsiflexion is very little, then you can passively try to see whether you can get more. Okay, so same macam your knee examination. If there is some restriction that you find compared to the other side, you can try to passively see if you can get a bit more. So whether you differentiate whether the deficit is because of a muscle weakness or whether the deficit is because of a block. Means you try passively also you cannot get. Understand? Okay, so look, feel, move, and then neurovascular screen. So what's your neurovascular screen that you want to do?
Sensation.
Okay, pulses where?
Dorsalis medius. Posterior tibia. Okay.
Okay, so you all know the landmark? Lateral to AHL or whatever nonsense, but I feel like bony landmarks is the best because tendons and other things will move around. Okay, so bony landmark is usually it goes between the base of the first and second metatarsal. Okay, and then your tibialis posterior is directly behind your medial malleolus. Okay, so everyone practice feeling their own. I've seen housemen feel for the tibialis posterior pulse behind the lateral malleolus. Please don't do that. When your ward round specialist asks you to palpate the pulse, tell him what it is.
I like
Then cari belakang lateral malleolus. Okay, don't do that. And then the other screen is
Sensation.
sensation. Okay, so sensation. How many types of sensation screen do you know? Okay, sorry, how many types of sensation examination do you know?
Dermatomal.
Dermatome, very good. So what you see behind you is dermatome, okay, which is related to your nerve root. Correct? Okay, second type is? Peripheral nerve, very good. And then one more?
Proprioception.
Sensation.
Spinal cord.
Spinal cord will still be dermatome. Yes, glove and stocking, which is important for you because this is for your diabetes punya foot examination. Okay, so diabetic foot examination, sensation is very important for you to establish in a glove and stocking type of distribution. Okay, so you have a sharp. Anyone has an orange stick?
Why you sighing, man?
So sacrifice the orange stick. Okay, never mind. Sacrifice this pen. Okay.
So relaxed.
Cut it beforehand. As in like use the scissors and cut it so that it's sharp straight away. Because you don't want to be and then alah tak cukup tajam and then wasting time trying to break another one and hey, you are under exam, you're like in the stress, your heart rate is 150, you know. It's not the time for you to be doing this during exam. Okay, so when you go for exams, make sure that it's already broken and it's already sharp. Rather than you break it, then got a lot of splinters, then you want to test, alah, not very sharp, not sharp enough. Right? Okay, so you're going to do your sensation depending on what you suspect. Okay, so most of the time it's a peripheral nerve distribution. Okay, because basically we're doing dermatome punya distribution when you are doing your spine neurology examinations, correct? Okay, so most of the time peripheral nerve distribution. Can you tell me what peripheral nerves around the foot and ankle region? Common peroneal nerve will divide into the
Superficial and deep.
Okay, so where's the superficial peroneal nerve punya sensation?
Everywhere except the
Okay, so it is over the general dorsum of the foot. Okay, how many times you want to poke? Poke one will say 2. Okay, 2 enough. You don't want to do so many times to make the patient feel pain. Okay, so I'm just going to use the blunt end. I shouldn't have broken this in the first place. Okay, So 2 is enough. One is for the patient to localize where it is, and the second one is for the patient to discern whether it's sharp or blunt. Okay, make sense? Okay, and then so your common peroneal nerve divides into your superficial and your
Deep.
where is the sensation for the deep?
Between your first and second.
Okay, is at the flip flop area. Okay, so it's the first web space. Okay, dorsum first web space. You know you wear a slipper chapal
Yes.
with the batang kat tengah-tengah. Okay, so it's a first web space. Okay, it's called the flip flop area. Flip flops lah. Your slipper lah, your flippers. Alright. Someone what sensation? What nerve?
Saphenous nerve.
Okay, where's your sural nerve?
Second.
No.
Lateral
So
side.
dorsum foot is already kind of covered. Lateral side of the
The foot.
heel.
Heel.
Okay. Some more.
Sural.
Yeah, this is sural. Lateral side of heel.
Saphenous.
Okay, where's saphenous?
Medial aspect.
Very good. So medial side of the malleolus. Okay, saphenous nerve is the only nerve that comes from the femoral nerve. Okay, the rest are all from the sciatic nerve. So saphenous nerve is your terminal branch of your femoral nerve. Up here, then it goes down and innervates here. Okay, and then how about the plantar of the foot?
Medial and lateral plantar nerve.
Very good. Which are terminal branches of your?
Okay.
What nerve is behind here? Tibial nerve. Okay, so it's not posterior tibial nerve, it's only tibial nerve. Okay, so you have common peroneal nerve and you have your tibial nerve. These are the two branches of your sciatic nerve that they branch out in the popliteal fossa. You're going to jog your memory. Okay, the artery is called posterior tibial artery, yes, because there's an anterior tibial artery and then there's a posterior tibial artery. Okay, but the nerve is called tibial nerve, so it's not a posterior tibial nerve. Okay, your anterior tibial artery is the one that becomes dorsalis pedis. Once it crosses the level of ankle joint, it just changed name. Why you want to change name? Ask the people who named it. I don't know. Okay, but basically it's anterior tibial artery here, crossing the ankle joint, it changed name into dorsalis pedis artery. Okay, so it has a posterior tibial artery. But for the nerve, it's just tibial nerve. Okay, so tibial nerve, and this is where your tarsal tunnel is. Okay, so on the medial side here, so in your counterpart of the carpal tunnel lah. Okay, carpal tunnel here, tarsal tunnel here. Okay, so your neurovascular here, and then the tarsal nerve can be entrapped. So the tibial nerve, as you pass through here and goes to the bottom of the foot, will divide into two terminal branches, which is the medial and the lateral plantar nerves, innervating the sole of the foot, medial and lateral. Okay, so same 1/3 and 2/3, 1.5 and 3.5. Okay, like your hand. Okay.
So the lateral nerve is the
Here and a half.
gain.
Okay. So medial is 1.5. Sorry, medial is 3.5. Lateral is 1.5. Okay. So this lateral plantar nerve, medial plantar nerve, and then there's also calcaneal branches lah. Okay, all three from the tibial nerve. Okay. So the saphenous nerve is already around the medial malleolus. The sural nerve is around the lateral heel. Okay, and then just now your superficial peroneal nerve and your deep peroneal nerve. Okay, so these are a few places you need to screen, but I think because it's a screen, you just screen the superficial peroneal nerve and then you screen either the medial or lateral plantar nerve. It should be okay. Okay, so dorsum of the foot, plantar of the foot, if you find that there's intact, then it should be okay. Alright, so dermatome, of course, is different. You have to remember lah, your L4, L5, S1. These are the ones that cover the foot region. Okay, but I should not cover here. Okay, how about your glove and stocking distribution one? How do you do it?
Distal.
Distal to proximal. Very good. Distal where? Plantar, dorsal, medial, lateral?
Dorsal.
Okay. You can do any one. Plantar, medial, lateral, dorsum, it doesn't matter. But the easiest accessible one is dorsum. Okay. So your instructions to the patient is going to be very specific. Okay, it's going to be different from the normal instructions that you give when you are doing the normal sharp or blunt thing. Okay, what you are going to tell the patient is, Pakcik, saya nak test, nak tengok ni tajam ke tumpul cik?
Tajam.
Tajam Okay, sekarang ni tajam ke tumpul ke tak rasa?
Tak rasa.
Okay, tak rasa Okay, saya nak test sampai pakcik rasa tu pakcik bagi tahu
Baik. Okay, rasa.
Okay, so then you find that, okay, so he starts feeling at the level of midfoot. Okay, pakcik, once benda ni dah start rasa tajam tu bagi tahu
Tajam.
Okay, so there is loss of sensation. Blunt is ankle downwards. Okay, so you're going to be poking successively from distal to proximal. Okay, how far apart? Boleh lah budget like maybe few mm apart, 1 cm apart. Okay, until the patient feels sharp. Your instruction is very important. You have to make sure the patient understands. Pakcik, first you test. If your hujung tu tajam already, then there's no glove and stocking distribution loss lah. Okay, your hujung tajam. Okay, don't need to proceed. Hujung, you stroke the hujung of the big toe and the patient say tak rasa. Okay, then you proceed. Okay, pakcik, masa dah rasa tu bagi tahu ya. Saya nak test dekat sampai mana pakcik hilang rasa tu. Okay, clear? Important for your DFU examination. Right, so neurovascular screen. Okay, for DFU examination, I'm a few extra neuro things that you have to do. What are they? Okay, proprioception. Some more? Very good. You want to mention that you want to complete your examination with a monofilament test. If you have the time, of course do. But if you don't have the time, you mention that you want to complete your examination with monofilament. Some more? One more component that you should do. Include. Okay, reflexes is one, but sensation. Pinprick sensation, proprioception, monofilament, yes, vibration. Which tuning forks do you use?
128. 1 to 8 hertz.
1 to 8. Which one is that? Shortest one, the middle one, or the longest one?
Shortest one.
Hey.
Just take the one that tulis 1 to 8.
Yeah, when you are in exam, your mata rabun. You're not going to see the small number there. There's only
You have to see.
they only give you the 3 size. Okay, actually tuning forks got millions of size, not millions of size. Got multiple sizes lah. But the one that we use in medical, only 3 size: 1 to 8, 5 to 5, 6, and 512 hertz. Okay, so which one is the shortest and which one is the longest?
Longest 1 to 8.
Longest is 1 to 8. Okay, the shortest one you're using for?
Ear.
Yes, your Rini and your Weber examination. Correct? Okay, that's the shortest one. So you want to take the longest one for your vibration sense. Where are you going to put it? You put it into it. Okay, ting, or you ting, okay, ting already. So the first bony prominence is?
Big toe.
Okay, so you can put here. Alright. If it's lost, then you go to here. Okay. If it's lost, then you can go here. So the subcutaneous border of your tibia, or head of fibula sometimes also very hard because people can be quite fleshy. Fleshy or muscle lah. But okay, subcutaneous border of the tibia is quite easy to identify. You can put it here. Usually here, if the patient also tak ada, then quite gone lah captivation.
Yes.
Okay. Right. So 1, 2, 3. But if you put it down here and patient can feel already, then okay lah. Right. So after that you can report there is a loss of vibration sense at the level of the ankle or whatever. Okay. So proprioception, you all know how to do, right?
Ask the patient to close their eyes and then localize the joint of the big toe. And then
But
Hold the
you
side.
should not hold
Yeah.
this way. you need to make sure you hold this way. Okay, otherwise your patient can sense the pressure up here or down here. Okay, so you have doing it sideways. Alright, so proprioception, vibration, sharp pinprick sensation, and then you, if you got the chance, you do your monofilament. Where are you going to do your monofilament? Anyone has a monofilament? Anyone has seen a monofilament? You all seen, huh? Yeah, but you all don't have it, right? I mean, I also don't have one, honestly. So you can say that you want a complete examination with a monofilament testing, which they will say tak payah. Okay, but where do you do the monofilament?
The head on the
Pick 4, 1, 3
Okay.
and 5.
So the classically is 10 points.
10 points.
Okay, all the white and the blue points.
MS.
It's quite easy to remember. Heel, medial and lateral midfoot, 135, 135, and then dorsal. Okay, so 3, 6, 9, 10. Okay. Okay, but if you don't have the time, this is enough. Anyway, I don't think you all will have the time or need to do this lah. See, I don't know whether they even provide you with a monofilament in the exam. Okay, but you need to know that this exists. And this is very important thing that you want to say. I would like to complete my examination with specifically for diabetic feet, not in other foot examination with your patient for your diabetic feet. Invariably, one or two of you will get, because definitely some patients will not turn up and will drag these fillers from the ward. Okay, so I don't really recommend putting here. I don't think there's a bony prominence there. Just start with the medial side of the big toe is enough. Okay, but you can see this is the longest scaling fork. Okay, and then your proprioception. Make sure you're not pressing up and down, but on the side. Okay. Special test.
Hey yo, it's not actually standard.
Yes. Wow. Why are you so good? What test is this?
Siemens.
What do you see in this picture?
No, actually standard.
Yeah. My houseman don't know this, you know. And I'm like your super senior. I graduated 2010. Super duper senior. Yeah, but I'm very sad that my houseman, that day we in the clinic, we had a very beautiful case of Achilles tendon rupture and he doesn't know this. It's very sad. Okay? So you can see loss of the normal tendon architecture. You can see the foot is not as plantar flex. Can you kneel on the couch or is it not balanced? So you can see that actually when you are in a relaxed position, the foot is more plantar flex. Because our plantar flexors are stronger than our dorsiflexors. I mean, of course it's stronger. You have this big, mighty, powerful Achilles tendon. Okay? Compared to your anterior tibialis tendon in front there. Okay, you got Achilles tendon, you get the posterior tibial tendons, all these things are strong. And then the resting position, naturally the foot is more plantar flex. Okay? So you see loss of the normal Achilles tendon, you see that the foot is more plantar flex. And when you do this, what is this? Another name? Okay, so two different names, same test. Okay, Simmons or Thompson test. When you squeeze it, you can see that the foot goes into plantar flex, but the abnormal foot will not move. Okay, alright. What other special tests you all know? What other special tests you all know? Okay, so the ankle also has a drawer test. Okay, this is for deficiency of the lateral ligament, which all of us have sprained before. Okay, the ATFL, or anterior
tibial
talo, not tibio, talofibular ligament. Okay, there is a anterior tibiofibular ligament. There is one, which is your syndesmosis. You know your syndesmosis in between your distal tibia and your fibula? There is one, yes. Okay, but the one that we are talking about here is not the tibiofibular ligament. It's the talofibular ligament. Okay, so how you want to do that? When the patient is sitting on the couch. Okay, so you are going to posterior force on the tibia. Okay, and then you can either, if your hand is big, you can cup like this. Okay, but if my hand is small, I prefer to cup like this. Just relax. Yeah, I prefer to cup it like this. Okay, so ligament is quite firm. You should always compare with the other side. Okay. What are the chances you need to do this in exams? I think not. Just know that it exists lah. I don't think so you're going to get a ligament laxity case in your exam. For foot and ankle, most likely is DFU. Otherwise, some degree of deformity, either pes cavovarus or pes planus. Okay, so most of it is going to be, when you score, most of your score is going to come from your description. So description of deformity itself, which is very important. Okay, high arch, heel infarus, crossos, all these things, all the keywords that you have to mention. Alright, so if you're examining the patient on the couch, you can also do that.
DFU.
Right, so remember, your ATFL is here. Okay, so refreshing of your memory. Okay, you also have your CFL and your PTFL. So there are 3, but the most commonly taught is the ATFL. Right? Okay, so this was the Jack's test that I was saying just now. If you have a patient with flat feet and you want to show that it's a flexible type, you dorsiflex the toe to make the arch come back. Okay. So if it's a rigid type, the arch doesn't come back. Okay. And if you have a patient with flat feet, you want to see whether the patient has hyperlaxity associated. Have you all heard of this before? Okay. This is called the Dayton score. D-E-I-G-H-T-O-N. Yeah, no, it's not written anywhere. Dayton score, okay? So there's a total of 9 components and a score of, this one it says more than 4. Some people take it as more than 7. Okay? 4 or more or 7 or more says that it is hyperlax. So can all of you do this? Anyone's thumb can touch the palm?
What? You better do this. Touch your forearm.
Okay, so give one point for each. Let's all test whether we have
So my friends
hyperlaxity.
can.
Okay, if both your thumbs cannot touch, then it's 0. If one can, 1. If both can, then it's 2 points. Little finger down. Is it more than 90 degrees?
Nah. Oh shit. Dislocated.
2 is
Okay, so
Insane.
you have 4 points already, is it?
What?
more than 9.
Okay, Naeem has 4 points.
More than-
Anyone
more
has
than
higher
90
points
lah.
than Naeem? No?
Go some more.
Cruciate ligament and
I don't dare to do a pain. I can go
Or legs.
17.
So
Okay,
hyperlaxity
makes you
lah.
feel alive.
Sure.
Okay, elbow.
Can't.
See your own friend's elbows. Is it more than 10 degrees of hyperextension?
Cannot lah.
Tengok Naeem punya.
Cannot do
Naeem di depan dia.
I think my
Okay, hyperlaxity
It's a good thing.
is not a good thing. I mean, it's not a normal thing.
America
Just that some people are hyperlax. That's all. Okay, so you have to make sure. Okay, this one not really lah. Take his elbows out.
A bit lah.
Maybe 10 degrees.
Hug him from
Okay,
behind lah.
show the thumbs and show your thumb and your little finger.
Hey, no.
Alright, so it's supposed to be able to touch the forearm, then you get 1 point there. Okay, little finger bend more than 90 degrees. So there's 4 points here already.
I don't know
1,
why.
2, 3,
All
4.
the
Okay, then elbow.
Damn.
And then one more is the knee. And you stand facing the whiteboard. Facing the whiteboard.
We want to see the lateral side of it.
Oh, whiteboard over there, sorry.
Like on the board. Lagging for a moment.
So you have to, of course, the patient should be exposing the knee lah. So you want to see whether there is a increase in the hyperextension of the knee.
Yeah.
Okay.
The last
And then
one
another
is
one, can you lean forward and touch the ground with your feet, hands like Right? Okay. Thank you, Naeem. So how many scores does Naeem have?
Yeah, bro.
1, 2, 3, 4, 5.
Got 麻烦.
Okay. Depending on which literature, some say 7 or more. Some say 4 or more. Okay. Then you fulfill the criteria of hyperlaxity. Okay. So if you have the time, you can complete with this. Let's say if you are facing a patient with flexible flat feet, you can complete with this to see whether there's hyperlaxity that's associated with the flexible flat feet. If you don't have the time, you can always say, I would like to complete my examination by completing the Baton score. Wow, then your examiners will be like, wow. Okay? So, special test you know? That you want to ask me about? I think foot and ankle, not much,
Special test.
yeah, not much special test. No. Not like your knee and all very so easy to remember. Okay, so the main point about foot and ankle examination is the deformity. That's all you need to remember. As long as you divide in your mind forefoot, midfoot, hindfoot, and you describe accordingly. Okay, hindfoot, there's varus valgus. Midfoot, there's high arch, low arch, flat foot. Forefoot, there's a big toe or lesser toe deformity. So claw, hammer, mallet, varus valgus, blah blah blah. Okay, as long as you can divide that, and then you see the gait, should be okay. But of course, diabetic feet, you have to remember your ulcer examination as well. So the patient that we give you from the ward invariably will have an ulcer that has already been debrided or pending debridement infection. Okay, so you can do your general deformity description first, then only you describe the ulcer. Okay, then only you move on to feel and move. Okay, clear? So ulcer description can happen after your general deformity description. Okay, this patient, there's absence of the 4th and 5th ray, maybe from a previous surgery before. Okay, there's clawing of the 1st, 2nd, 3rd ray, or the 3rd toe is deformed. Okay, there's an ulcer over the plantar base, plantar midfoot. Okay, so this is how you describe where it is. Okay, plantar forefoot, plantar midfoot, plantar hindfoot. Okay, this is how you describe where it is. Oh, another test I should teach you. Silver squat. Have you heard of this test?
No.
What is that?
Okay, silver squat test. I should include that in my slide. I'm going to Google it.
Okay.
When you are faced with
Small test.
a limited dorsiflexion of your ankle, okay, so it's okay. So his ankle is actually very good in dorsiflexion, right? So active dorsiflexion is very good. But if your patient has a decreased active dorsiflexion, and then you passively try to dorsiflex also, it's still like that, you can get like neutral. You want to test whether the tightness is from the Achilles tendon or something else, or is it because of the gastrocnemius that is tight. Okay, then we do the silver squat test. So what we do is, here in knee with full extension, maybe you only can get neutral. So you bend the knee, and if you see there's increase in dorsiflexion, that means it's positive. What is the science behind this test? Okay, can you remember where is your gastrocnemius attached? Yes, condyles of the femur.
Silver
So your gastrocnemius,
Silver spoon. Silver spoil.
silver spoil.
It's Swedish.
Silver spoil. Okay, gastrocnemius attaches to the posterior condyles of the femur. So it actually crosses the knee joint and crosses the talocrural joint and crosses the subtalar joint. Crosses 3 joints. Okay, we insert in the Achilles tendon. Whereas your soleus attaches to the posterior aspect of your tibia. So your soleus muscle does not cross the knee joint. Okay, but your gastrosoleus muscle forms the Achilles tendon. Alright? Okay, so when you have stiff ankle, I mean your ankle cannot dorsiflex much. Okay, and then you try to push it up with the knee in extension, you only get this much. You flex the knee, relaxes the gastrocnemius muscle, and then you find that you can dorsiflex the ankle more. This means there's a positive cervoscoid test, which indicates that the ankle lack of dorsiflexion of the ankle is because of a tight gastrocnemius muscle. Okay, if your cervoscoid is negative, then maybe your whole Achilles tendon itself is tight, or you have a bony block inside the ankle joint, or something else is blocking from dorsiflexion. Okay, understand? So the cervoscoid is just to exclude the tightness from gastrocnemius muscle. Okay, doesn't exclude the tightness from anywhere else. Okay, but because it's so common, a tight gastrocnemius muscle, that's contributing to reduce in dorsiflexion. So there is this test. This is one test that you can do if when the patient does a active dorsiflexion of the ankle and you see it's limited. Okay, then you can do this test. So of course all these special tests you don't simply do. You only do when it's indicated. Okay, you're not going to do a Thompson test on all patients. Only if you suspect it's Achilles tendon tear, then only you do it. Okay? Yeah, similarly, you're not going to do an anterior drawers test on all the patients unless the patient comes to you complaining of in your knee, when you have rupture of ACL, what do your patient complain? Unstable. So same like your ankle, patient complain of instability. All your ligaments are to make the joint stable, correct? So same like your knee, when they rupture the ACL or PCL, they say it's not stable. When they are running, pivoting, they feel like the knee not stable. Okay, so your ankle also, when you are deficient in ACFL, patient will complain, running up slope or walking down slope, heels, uneven surface, ankles feel like easily want to give way. Okay, so you don't do your special test in all the patients. Right, any questions?
Dr. Nik, show us how this passive movements, which place to fix the
Okay, dah pakai kasut already. Kesian. Buka balik. Just open one side lah.
Show passive and range of movement.
It's okay, just one side. Okay, so obviously the ankle joint is very clear lah. Okay, so you're going to fix your talus, your tibia, and then the movement is across the ankle itself. So you cannot really fix your talus. So you're going to be more of your calcaneum because your talus is so deep inside and covered by everything. Okay, so you're going to be more your calcaneum. Okay, so up and down. Okay, and of course your subfibular, your subtalar movement also, you're not really able to fix your talus and your calcaneum. So you're still just seeing like that. Okay, so whether it is able to move in or out. Okay, so when you're facing with a patient with a,
trying to isolate.
what are the combinations that you usually find for, let's say, flat feet? They usually all come together one. When the patient has flat feet, the calcaneum is, tadi you saw the picture. valgus. Okay, the arch is collapsed. Correct?
Yeah.
Tadi you saw a picture, right? The calcaneum is very valgus, right?
Valgus, yeah.
Okay.
Ankle is valgus.
Okay, the arch is collapsed. And then the forefoot
Is
is,
abducted.
yes, abducted. That's why you got so many toes. Okay? So these usually always comes together. So on the opposite side of the spectrum is
High arch. foot.
high arch. So the heel usually is
Varus.
varus. The midfoot is very high.
High.
And then the forefoot is
Adducted.
adducted. Okay? Right? So usually they all come together one. That's why it's called pes plano valgus and pes cavo varus. Plano is flat. Valgus is heel is outwards. Right? Pes cavo varus. Pes plano valgus. Okay? So usually it comes together, the deformity.
The first term pus means for
Pes is feet.
feet.
PES. Pes planovalgus or pes cavo varus. So cavo is cave.
You know, the same.
High arch. Cave. Okay? So how to see for supination, pronation? You fix the calcaneum. Okay, then after that the forefoot punya passive movement, supination, pronation, you fix the calcaneum. You are able to pronate, supinate the forefoot and also to some degree abduct and adduct. Itu je lah. Okay, this is for passive movement. Okay, forefoot got these two passive movements, and then the hindfoot is your heel and your ankle. Right? So yeah lah. Sometimes you say if you got deformity, we should try to see whether we can correct the deformity. Then just now the Jack's test lah. Your arch. Okay. So Jack's test they actually describe is just big toe, but plantar fascia actually connects to all 5 toes now. So for me, I prefer to do all 5 toes at the same time. Then you can get a more pronounced correction rather than just correct and rather than just extend one toe. Okay, simple. Then you can score your diabetic foot examination. That one is really, if you